I'm doing this a little different because lower tissue appear to be a thickened tissue more than the upper, and of course it's thick bone and thick tissue, but this thick soft tissue is considered much thicker. So I'm performing, instead of internal bevel incision, this is an external bevel incision, just like a GV that you would do after initial marking around where the CEJ is. You can always determine from probing underneath the gum to detect where the CEJ, and then mark externally, so you can see the marking point, the marks on the apical extent of the CEJ, externally. And then we make scalloping and overlapping the scalloping interdentally, so that you will, for papilla tip, it's somewhat different from the upper. Upper, we will try to maintain the tip height. Now this we will maintain the tip height internally, not externally. We do not remove internal soft tissue height, but for this, for thickened tissues, we did this external bevel to try to thin the tissue ahead of time. Now, some people might ask, what if you do the same internal bevel? Then you will get a thickened marginal tissue. It takes a lot of time to trim it. Now, for external bevel, it's very important, three things. One is that there's no bone loss. Two is there's existing carotid tissue that is adequate. And then a third, that the MGJ is far enough, So you, after the trimming, you will have enough carotid tissues to protect against your gum, and so you have to have existing carotid tissue adequate to do that. Now, following incision, using 15C for external bevel. Now, the best instrument to follow after that is called gingivectomy knife. This is a pear-shaped gingivectomy knife. I use SOLT, S-O-L-T, SOLT knife 1-2. It's by Hugh Freedy. SOLT knife, gingivectomy knife, called number 1 and 2 instead of a Kirkland. To me, it's more efficient because the bevel of the blade is different. It's more efficient. Now this is back action chisel SOLT 3-4, that you remove the tissue color. So now this tissue removal is more than that in the upper because it has external part of the tissues. So then this step 3 always start from papilla thinning. Okay. Now it was a little different from the upper. I reversed this sequence a little bit, because upper we did papilla thinning first, and then we do color removal. Now for this, because the papilla was thinning externally, so we will only after that color removal can we see the internal papilla. Now we are thinning the internal papilla again because it's still too thick. Although we thin by external bevel, but it's not thin enough. So in order to make a good slim papilla, it's important that we make this papilla thinning across the tissues. Be sure that during the procedure you have good finger rest. Sometimes you have to go against some crestal bone a little bit. Now after that thinning and the crest, then we, and sulcular incision of course, and then we start elevating the flap, starting in between the tooth papilla first. All papilla was elevated, then following by between two papilla, the marginal elevation. Now the marginal elevation, and when you exposed enough the buccal bone, then you can use a larger elevator if you want to do it faster. Now, after adequate elevation beyond mucogingival junction, now you can remove the excessive bone by grooving. This is called osteoplasty. We first thin the tissue, then to remove the supporting bone. Okay. So osteoplasty is to remove the thickness of the tissue to become make it thinner. So the movement is actually working from apical to coronal. It's better that way. So you have a better control when moving in between interdental area to have a better, I think, an angle of viewing. So you see how thin you can get in between. So making the groove. Now the grooving is a mid-sized round burr. Now this is a large-sized round burr. So it's more efficient to remove any thickened tissue buccally. Interdentally, we have made the groove already. And then we connect two grooves with this burr to make sure that you try to disappear the groove, so that it's not become noticeable of the grooves, and you see the shape of the external cortical bone to be very thin and regular and good convexity. And step 6 again is the papilla thinning. We don't do any bone recontouring in between interdental papilla area. We don't expose even bone for the aesthetic crown lengthening. But we have to trim this papilla, make sure it looks flat, it looks even thickness. So after trimming, the step 7 is following osteoectomy. Osteoectomy start with the end cutting burr to expose enough root surface underneath the CJ. How much is enough? Is I always consider 3 millimeter to be an adequate vertical length for the attachment of biological width, and with a minimum sulcus of 1 millimeters. So that would allow you to expose the full clinical length of the crown. The longer, closer, the length of the clinical crown closer to the CJ, the better. And this is osteoectomy. After margination, you will see that the marginal bone will become thicker. So you have to use the osteoplasty burr again to remove all the thickened bone crest or bone ledges. Okay, but be very precise and careful for removing all the supporting bone using the end cutting burr. You don't want to aim against a root. I said aim against the crest of the bone. Now this is aiming against the root using this PDL removal burr, a non-cutting burr to remove PDL. Now you can do this is a step 6 after 7. Now you can do that also after 8. Just suit yourself as long as you make sure that there's adequate bone removal after underneath the CJ, and there's no remnants of we call it PDL cell. The remnants of PDL cell is considered as widow pigs. Widow pigs will allow the tissue to regenerate. The bone will come back, and then you have not so ideal crown lengthening of this area. Now we initiate a suture in between two centrals using the same procedures again that was utilized for the upper. And so this is called vertical matrix reposition flap suture, and so there will be no crossing over stitches on top of the papilla tip. It will be going always underneath the papilla tip, but by suturing tight enough to make sure that it's actually suturing back to its original position, to the position that we know where the CJ is. We will you can actually control the position of the papilla tip or the margin by tying the nuts. Okay, you don't want to make it a coronal position 1. You want to make it a reposition 2 prior to the position prior to elevation. Okay, so And this is the second suture. The suture I'm using for the lower is different from the upper. Now, upper I'm using a 5/0 nylon. Lower I'm using 5/0 chromy gut. Okay, nylon is good choice, and I think it's cheaper and it's easier to use. A chromy gut is it's better in color because it's this kind of color is not visible for the patient. If the patient has a major aesthetic concern after the surgery, they don't want to see the dark thread. So this will be one of the consideration you can try to use. Anyway, this kind of suture, we don't remove the sutures. It will disappear by itself in about 2 weeks. If not, then you have to remove it around 2 to 3 weeks. But removing the stitches could be somewhat painful because we suture against pretty tight to the tissues, and then pulling the threads away, sometimes causing some discomfort. So in some cases, for patient that has complained the suture removal or the dark color appearance of the suture, then we will use this type of sutures. So after the first and second and the third, still vertical matching. Now this is an elevator, we call it Allen elevator. It's called P9 it's called Allen Pitt Allen. It's PA9. Okay. Allen periosteum elevators. Okay, there's a hole that allow you to puncture, in particular when your needle is getting dull or old. Sometimes we have to replace. For sure, we will need a new one if very dull. But it's just after several puncture, it will become not as efficient. Then you can utilize the periosteum elevator to help penetrating a thicker tissue or very thin tissues. Okay, so we started from the base of the papilla tip, and then and immediately puncture through from inside out to the lingual papilla, and then coming back from outside in and inside out for the fourth puncture point. Now this you can see if it's very thick, then you have to use the periosteum elevator with hole in it to hold against the puncture point, and it would facilitate the easier penetration of the needle. So when you make a nice tie against the root, now the papilla will return back to its original position and together with the marginal tissues. So this kind of suture, I did it almost more than 20 years now for aesthetic chronic. I never changed using it because I get unanimous response from patients that they didn't complain anything after sutures, normally except for colors if you're using nylon, and or suture removal when you have to remove it. But for the healing during a healing period, for crown lengthening, a lot of time patients will complain that teeth become too long, and then before the migration of the marginal tissue back to its original the position that it should be, because you are performing apical position flap sutures. You don't do that now. Figure 8 is a little bit more apical position type of sutures. You can allow the tissue to apical position a little bit. Now vertical matrix for apical position, that will anchor much apical to get tissue that looks longer than it should be ahead during the healing. And what's worse is the compression against the papilla tip, and sometimes there's some black holes in between during the healing, and I don't like that. I don't like to have any consequences that the patient will complain towards that. Now this is the suture. We did it different. This is a figure 8. Okay, it's not vertical matrix. Now this suture, because at the distal of the canine, I consider it a secondary aesthetic area. So this is apical, a slight apical position to bring the tip of the papilla, back together, but a little compressed apically. This will allow the tissue to heal with some the dark holes. In some cases, in particular, if a patient had a thin biotype with very thin and tall papilla tip, okay, and we don't want that to happen during the healing. In that case, we should consider for the aesthetic zone using the vertical matrix for coronally or repositioned suture. Now this is after the healing, after the suture. This is the following the healing. This is a 1 month healing, and now there's 3 month healing. As you can see, the line before and after. Now this is the smile, the change quite dramatically. You can see the patient very satisfied with the result. And thank you very much. Please watch all other video if you're interested in my clinical presentations of some ideas about papilla, about aesthetics. There are some channels that you may want to look into.